righty. Well, hi everyone. Welcome to the 2024 Sibley lecture as a part of the McMaster Education Research, Innovation and Theory, or MERIT rounds. Thank you to those attending in person, but also those joining over Zoom. I am Dr. Elif Bilgic, to those of you who don't know, and I'm an education scientist in the Department of Pediatrics and also MERIT. And the MERIT program is an education services program in the Faculty of Health Sciences dedicated to an advanced health professions education scholarship with a vision to grow a community of scientists and clinicians to advance health professions education through research and applied science. And we have Dr. Chris Watling, who's our Sibley lecturer. Just in terms of the Sibley lecture, this is a lecture named after John C. Sibley, who was one of the first directors of postgraduate education at McMaster. This lecture and the subsequent awards are only possible through the donations by the Sibley family. You will hear more about the award winners at the conclusion of the lecture. But before I say a bit more about Dr. Watling, I would like to make a land acknowledgement. And today's Sibley lecture is hybrid. And many of us in this event are connected by the land on which we work. So I take this time to recognize that McMaster University is on the traditional territories shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, which was acknowledged in the District of Wampum Bay. The wampum uses the symbolism of a dish to represent the territory and one spoon to represent that the people are to share the resources of the land and only take what they need. Now, before leaving the stage to our esteemed guests, I will provide a very brief introduction. So the title of today's Sibley lecture is Towards a Coaching Culture in Medical Education. Dr. Chris Watling is a professor in the Departments of Oncology, Clinical Neurological Sciences, and Family Medicine at the Schulich School of Medicine and Dentistry at Western University in London, Canada. He's the Vice Dean of Education Scholarship and Strategy, and the director of the Schulich Center for Education, Research, and Innovation, in addition to a faculty scholar at Western University. In June 2024, he will begin a new role as CEO of the Royal College of Physicians and Surgeons of Canada. A neurologist by clinical training, he holds a master's in medical education from the University of Dundee and a PhD in health professions education from Maastricht University. His research, widely published in medical education literature, explores how and why feedback influences learning and how medicine's professional culture shapes its educational practices. Now, during his lecture today, Dr. Watling will describe the intended function of formative assessment as coaching, explore the challenges of realizing its potential in medical education context, and suggest some ways forward. Now, for those joining over Zoom, feel free to use the chat for comments and questions, and we will have a Q&A period at the end. And for those joining in person, you can simply ask your questions directly. So without further ado, Dr. Watling, please go ahead.
Well, thank you very much. It's a privilege to be here at McMaster, which has been, the source of such important progress and research related to education and medical and health professions education over the years. It's really an honor. So thank you for the invitation. So as a researcher, I primarily like to problematize things. To be honest, I like doing that a lot more than I like dreaming up and implementing solutions to those things, although I won't shortchange the view toward the ultimate need for some solutions to these problems at the end of what I talk about today. But I do think problematizing actually serves a really important purpose. A lot of times we get frustrated that we're not making the kind of progress on things that we would have hoped. We might think that by now we should be doing things better. We might have thought that things might have progressed more easily. And I think a lot of times the roots of those frustrations are simply that we just haven't understood the problems that we're trying to solve quite well enough. So I am going to talk about coaching today, but not right away. Coaching in medical and in health professions education is often promoted as a kind of a solution. And so it's, I think, useful to think about what is the problem that needs a solution, How effective is coaching as a solution to that problem? And what kind of thinking about it would we have to do, or different thinking would we have to do to really realize what we think is its potential? So I'm going to take a little detour from coaching and talk about formative assessment, because I think formative assessment in education, in clinical education, is actually a problem that coaching is being proposed as a solution to. So let's try to understand that problem a little bit. I want to just give you a little bit of a historical context, first of all. Many of you have probably heard this maxim that assessment drives learning. I don't know that that's exactly true, but it certainly drives learner behavior, if not learning. And around the 1950s, education researchers started to caution educators to be really careful with what they were doing with their assessments because of their potential to be detrimental to learning, because of their potential to drive people to learn in ways that might not be what the educators would have intended. And then it was a relatively short time after that that educators started to think strategically about assessment. Well, given that it seems to be shaping learning and learner behavior, could assessment be used strategically to try to guide learning in the directions that might have been hoped? And by the 1960s, educators and education researchers were starting to distinguish two forms of assessment. Summative assessment, which you'll often see defined as assessment of learning, and formative assessment, or sometimes it's defined as assessment for learning. So assessment of learning, summative assessment, really just means a decision, a judgment about the extent to which a learner's achievement of certain standards has been satisfactory. Formative assessment is really assessment that is intended to be developmental, to help facilitate learning. But I find it a little harder to get my head around exactly what does that mean. So here's a bit of an elaboration of this that I found quite helpful. This is by Sadler. It's many years old. But he said that in order to engage with formative assessment, learners need to have three things. First of all, they need to understand what they're aiming at. They need to have a fairly clear understanding of the standard of performance that they are aspiring to. Second, they need to understand where they are, and they need to know something about the difference, have some insights into the difference between their current performance and that aspirational standard. And then third, really important, they need to have a range of strategies that they can draw on to move from A to B, to remedy that gap. It's interesting in how Sadler wrote about this, because he saw learners as actually ultimately freeing themselves up from the need to have teachers directly involved in this process. It would actually matter if we distinguish formative and summative assessment. After all, they actually basically rest in the same general process, gathering information about a learner's performance. But there's a really critical difference between the two, and that is not the process of gathering information or the tools that we use to gather it, it's what that information is going to be used for. Right? So with summative assessment, the information is used to make a judgment. And sometimes, not always, those judgments are quite consequential for learners, and they will often feel high stakes. They might really be high stakes. With formative assessment, that information that is gathered, the goal of gathering that information is not to make a judgment primarily. It is to try to support development, learning, and progress. The stakes are said to be rather low, and formative assessment is said to be less consequential. I think probably nobody has been more influential in the thinking about assessment than Kees Vandervoeten, who developed many years ago this utility model of assessment that is kind of all based on the idea of compromise, actually. Assessment can't be everything. It sort of has to be a balance of different features, and he really stressed that one feature we should try not to scrimp on is the learning value of assessment. And as people have built on his work, though, the expectations of assessment have gone up and up and up. It needs to be valid and reliable and trustworthy, but it also should be linked with meaningful feedback and meaningful coaching and tailored developmental conversations that help learners to progress. It's a pretty tall order. And then I think along comes the competency-based medical education movement and kind of ramps up expectations even further. That we will actually be able to make really sound decisions that the public can count on, that make sure that we've considered that people are achieving everything they need to in all the different areas, but at the same time, they're also learning from their assessment and they're getting tailored coaching and feedback. In response to this, Case and others have suggested a move away from individual assessment tools and toward assessment programs. And what's called programmatic assessment really involves assembling a range of tools to collectively create a trustworthy picture of how a learner is performing and to satisfy some of the demands of competency-based medical education. So the way that programmatic assessment works, I know many of you are in the midst of it or are familiar with this, but the idea is that we have many, many assessment moments. And each of those assessment moments, or at least most of them, are intended in the moment to be primarily formative. Those moments are meant to be low stakes, they're meant to be formative, and they're meant to support learner development and growth. But then we take all of those low stakes moments and we scoop them up and we sum them together, and suddenly the formative becomes summative. And all of that formative assessment added together allows us to make a summative judgment. Kind of a Swiss Army knife. And this kind of dual purposing of assessment is problematic. It's not, I don't think, an insurmountable problem, but I think it is one that we need to really be thoughtful about and grapple with effectively. Otherwise, assessment is not going to deliver what we need it to deliver, and that's actually true on both the summative side and on the formative side. So one of the key problems here is that people respond differently and interact differently with assessment depending on what they think its purpose is. Okay, so I want to tell you a little story that has nothing to do with medicine, but I think it illustrates something of this way in which people respond differently depending on what they think is going on. My favorite thing in the world to do is downhill skiing. If I could find a way to make a living as a mediocre downhill skier, I would do that. Many years ago, I spent a week skiing at Killington. Has anyone been to Killington? It's beautiful. If the snow's great, it's beautiful, and skiing is great. And I was kind of a so-so skier, so I did a ski week. And if anyone's done this, what it involves is taking lessons every day. So you get assigned to a coach, you have lessons every day, and I still remember, this is more than, I think it's probably more than 30 years ago. My coach's name was Tom Ohotnicki. I'd never met him before, I've never seen Tom since. But I will tell you that I am pretty sure that I have never improved in my skills in any area of performance that I've ever been involved in as much or as quickly as I did in that week. So it's really interesting to think about, what did Tom do that enabled that? So he would demonstrate beautiful skiing. He would give some advice about how to achieve that. He would watch me ski and then kind of helpfully, kindly point out the differences between what I was doing and what he was doing. And then he would let me try it again, and so on and so on. Lots of formative assessment. And I actually felt really free in my skiing. I felt free to fall. I felt free to fall on my face, and I felt really confident that if I didn't fall on my face, Tom would explain to me why. And then next time it would be better, and it was. But there was one moment during the week that I didn't ski free and easy. And it was right at the beginning of the week, at least the way they used to do this. And I think they abandoned it for all kinds of reasons. But at the beginning of the ski week at Killington, you actually had to audition so that they could figure out which group to slot you into. And you did that by, all the instructors were standing on the slope with clipboards, and then everybody had to ski down the slope and they said, just make some turns. And I skied really tight, and I thought once I got to the bottom that that was not a good example of my skiing at all. But that happened because that was actually not formative assessment. That felt very summative. stakes were not exactly high, although I felt like my whole week was going to be ruined if I didn't get slotted into the right group. And so that's a little something of the difference between what happens when you're working with a coach and you're very confident that what's happening is formative. It was assessment. Tom was making little judgments all along, but it was all intended to help me to progress, versus when it's a higher stakes judgment. So we interact with assessment based on what we think it's about. The other thing that's kind of complicating this is that teachers and learners are not always on the same page about what it's about or what it's meant to be about. Harold Bach, who's a veterinary education researcher, showed this quite nicely that veterinary students struggle, even when their supervisor was given an explicit coaching role, to distinguish their coach role from their assessor role. And he found that when assessment moments contribute to a summative judgment, that learners will interact with them primarily as if they are all summative moments. Chris Harrison's also done some interesting work on OSCE. So an OSCE is a classic example of usually a summative assessment. And they created a situation where students could ask for explicit, detailed, formative feedback after they had completed an OSCE exam. And what he found was the students who'd done the most poorly on the OSCE, who probably needed the feedback the most, were the least likely to ask for it. And that probably does not tell us that those are uninsightful students, but it does tell us that summative assessments are not generally a place that people go to get formative feedback. So while we might be comfortable blurring these things together, students actually tend to maintain a clearer distinction between the two. Suzanne Schulich has written this really great phrase that stakes are in the eye of the beholder. And it's another great reminder that we can all day long say that this is high stakes and this is low stakes, but it's not enough to just tell a learner that something is low stakes and expect that they're going to interact with it as if it is low stakes. If it's a low stakes moment that it contributes to a high stakes judgment, they are potentially going to view it as a high stakes moment. One of my favorite and frequent collaborators is Corey LaDonna, who's a terrific researcher at the University of Ottawa. She and I have studied what it feels like for learners to be observed in clinical settings. And we did this because, of course, direct observation is seen as an essential facilitator of both trustworthy assessment, hard to make a judgment about somebody's skill if you haven't seen them do it, and also about meaningful feedback, equally hard to offer useful feedback about a skill that you haven't seen. So we know that observation matters. We also know that it doesn't happen quite as often as we might like. And we were interested in really understanding what does observation actually feel like for the people who are under observation. So the first thing we found, which is not on the slide, is that everybody thinks observation is good for them. So they generally embrace it. Learners like to be observed in the way that they like exercise and they like pot royal. They know that it's good for them. They know they should do it. But it's not without problems. It feels distinctly uncomfortable, at least for medical learners, to have somebody watch them do what they do. This is an increasing issue as people get more senior and more advanced in their training. They feel stressed. Their anxiety goes up. But they also feel like it alters their performance. And not in some vague, oh, I feel like I did that differently way. We had people tell us very distinct ways in which they're aware of behaving differently. People would say that a checklist appears in their brain when an observer is in the room, and they start trying to check off the boxes that they think they need to check off, rather than just doing what they would normally do. Some people said that the way that they talk to patients changes. They adopt a more formal language. They're less likely to tell a joke. They're less likely to do any of those things they probably normally do that build rapport and that help them to connect with their patients. And as a result, they found that the presence of an observer sometimes altered their relationship with their patients or even undermined the trust that they were trying to build with their patients. But probably the overarching finding is that whenever an observer shows up, people think they are being assessed. No matter what you tell them, the reason is that the observer is there, they think it's an assessment. And when we think we're being assessed, we start to perform to the assessment. So learners would kind of create a performance that they thought was appropriate to the assessment. And as a result, they sometimes felt that what they had done was not really an authentic representation of what would have happened had the observer not been there. And they, they're right, but they're acutely aware of it. And so like my skiing example, when I had to do my audition ski and I felt like, well, that's not how my turns usually look. I probably would have been less inclined to listen to any feedback about those turns because I would have said, well, but that's not even what I do. And same is true of learners being observed in the clinical setting. When they feel like what you've just seen is not even an authentic representation of what they would normally do, then no matter what kind of relationship you have with them, it may be difficult to exchange either useful feedback or to make a trustworthy assessment judgment. Okay, so we just sort of throw up our hands and say this can't possibly work. Formative assessment is a nice idea that can never succeed. I think no, but I just wanted to give you a taste of some of the real challenges with formative assessment and perhaps some of the reasons why it tends to underdeliver in terms of what we hope that it would do. But I think the way forward, I think, is to change our perspective. It's very tempting to say that the problem is the individuals themselves. So maybe the solution would be to just train learners to be better at interacting with formative assessment. Or better yet, call up our admissions office and tell them that we need to start selecting for people who are oriented towards formative assessment feedback and being good users of that, because that will solve our problem. So I would argue that medicine, health professions generally, are full of such people already. We have in classes and residency programs, we have people who have thrived in situations where formative assessment is the norm. We have talented musicians and athletes and dancers and people who understand how to use formative assessment. The problem is not the people. I'm just gonna, if you'll indulge me one more story, I'll tell you a story of a study that I did a number of years ago and an interview that has really stuck with me because I think it just kind of crystallizes this notion for me. We were exploring the experiences of people who were medical trainees or practicing doctors, but who had also at other times in their lives trained to high levels of performance in other fields. Olympic athletes and musicians who had recorded albums. And this individual, who's an emerged doc now, she was a resident at the time and had trained as an elite ballerina before she went to medical school. And I was just asking her about what is the experience like of training to be a dancer. And she said, in the dance world, critique is highly prized. When was the last time you heard a student you worked with say that? Critique is highly prized. So I asked her to explain. And she said, well, first of all, how could you make any progress as a ballet dancer unless you had somebody watching you carefully and critiquing what you did? Okay, that's not very surprising. The second thing she said was quite surprising. She said, in ballet, the worst thing your instructor could possibly say to you is, that was lovely. Because that actually indicates, at least in that world, that the instructor doesn't really think you have any potential. You're not actually worth constructing useful critique for. So the active critique, or what we would call negative feedback, is actually a tacit endorsement of the learning potential of that individual in that world. I'll confess that I only ever had one part-time job in my life. Through undergrad and medical school, I played the piano for ballet classes. So I have sat through more of these classes than you can imagine. It's a really rough world in there. If anyone's ever taken a ballet class, it's harsh. The other thing that I noticed that really resonated with me about her story is that I often observed that the harshest critiques, at least from my perspective on the piano bench, seemed to be reserved for the strongest answers. So that just tells you something about the cultural significance of critique. And it really got me interested in this whole idea of learning culture. So when we talk about learning culture, I'm talking about the customs, the beliefs, the language, and the values that constitute the environment within which learning occurs within a particular profession or discipline. I'm a neurologist, and so when I initially started doing research in learning, I just kind of assumed that all learning occurs here in the brain and mind of the individual, and I would never suggest that that's not part of it. But there's also a sociocultural view on learning, which says that learning occurs here, you know, in the interactions between people and others and the environment and the context that they work in. And if you think about things from a sociocultural perspective, you would say that in the health professions, people learn by gradually becoming members of a professional community. And as they do that, they gradually absorb the beliefs and customs and the language and the values of that community. So if you buy that, then it suggests that we need to pay very careful attention to the issue of culture as much as to how individuals are behaving if we're going to make some progress. And my overarching sense here of why we often feel stalled in making things better in health professions education is because we tend to look almost exclusively at individuals and we don't pay very much attention to this very important cultural issue. Matters a lot. My ballet dancer colleague would tell you that her comfort with critique as a dancer did not extend to feeling comfortable getting criticized as a medical student or a resident, because the culture was just so different. So now I'm going to talk a little bit about coaching, because if we think of coaching as an advance, as a potentially a different way of looking at formative assessment, maybe a more productive way of looking at formative assessment, we need to also look at what is a coaching culture. And if we think of sports and music and dance and what is at the center of the way people learn and train and develop in those fields, those areas do have a coaching model or a coaching culture. Of course, you'll see in the media that there's all kinds of problems with their coaching culture, but I'm not going to talk so much about the problems today as what it's intended to do and what it often does deliver. This is timely, I think, because coaching is kind of everywhere. At least in the medical education literature, probably one of the things that started getting people interested was this article by Atul Gawande in 2011. It was published in the New Yorker, which just goes to show that you have more influence if you publish in the popular press and not in the academic press. And I think the subtitle of this article was Top Athletes and Singers Have Coaches, Should You? And the article described this situation where he, as a relatively experienced surgeon, invited a very senior colleague of his to come and watch him do surgery and then to try to give him coaching. And, you know, what he described was that he thought it was useful and it felt incredibly uncomfortable and weird for both of them. So, with my collaborator, Corey, we decided that one of the things that the community really needed to understand better was what is coaching anyway? What do we mean by this? Because I think we have a bit of a tendency to just say, I think we could fix this if we just told everyone now you're a coach. And just act like a coach. You all know what coaching is, right? And we thought maybe we don't know exactly what coaching is. And if we can understand it better, maybe that would put us a little further ahead. So Corey and I studied varsity sports coaches at a university level, and also some medical doctors who were highly trained as sports coaches. And so who kind of had that experience of both. And a few doctors who were not sports coaches, but strongly felt that the work that they did in the medical education sphere was coaching. By putting these kinds of perspectives and experiences together, we wanted to try to distill the essential features of coaching. And here's some things that we think. And they were remarkably universal. Coaching is about unlocking human potential. So this is one quote from a sports coach. For me, it's all about that person reaching their own personal goals and being the best they can be. Of course, we didn't study professional, high-paid sports coaches, and I expect that some of the experience might be different. Varsity sports coaches really have a lovely orientation toward student development as humans. Coaching has a really interesting mutuality to it. This quote here, the language is about we, comes from a psychiatrist. But he wasn't talking about psychiatry training here. He was talking about his other life as a really highly skilled ski instructor. So that's a discussion about what ski instructing feels like to him, or ski coaching, which is really centering what we are working on together, with the coach being as flexible and as engaged as the learners. Third, coaches promote learner reflection. They try to promote and instill habits of reflection, which doesn't mean that the learner will never require a coach, but it allows them to continue to do some of that work even when the coach is not in the room, right? This is actually from an executive coach who talked about helping people to reflect on their situation, not telling them what to do, but helping them to reflect on what's going well and what's not going well and what they might do differently in the future. And sports coaches would talk about, rowers and training them to feel what the stroke looks like and feel the resistance of the water and learn to adjust to those kinds of things. So instilling those habits of reflection. That's maybe not quite so surprising as this one. Coaches spend enormous amounts of time reflecting on their own performance as coaches. That's a little different from some of the teaching that we often see in our clinical environments. This is from a physician, but who's also a hockey coach, and he's talking about the hockey coaching here, where he said that every time after every game, I would reflect about how today went, whether I reached somebody, whether something went well or didn't go well. Coaches talked about kind of at the end of the season, really taking stock about how things are going and what they need to do differently next time. And then coaching embraces failure as a catalyst for growth. Again, maybe not professional sports coaching, but this is actually a quote from a fencing coach at our university, who talked about the value of failure and how failure really can be the catalyst that helps people to go higher than they would have thought that they could achieve. So that's kind of the coaching philosophy. Lots of direct observation. Coaches are with their athletes all the time. Mutual engagement, they're both in it. Reflection, making space for vulnerability and making it safe to fail. And then everything really being about development over judgment. Yeah, in some ways it's a little easier in sports. The judgment occurs at the competition or at the tournament, or when somebody goes in front of the judges and the judges are not the coach. But the focus of the coaching is on development. So it sounds great, right? Let's do that. And so the challenge here is for us to just take a minute and think, well, what parts of that can we draw on? And where might we encounter some stumbling blocks? Things are quite context specific. And like my ballet dancer colleague, things that work in one context or feel comfortable in one context sometimes kind of fall apart when you put them in a different context without taking into account some of the adaptations that we have to make. So I want to just highlight a couple of the reasons why medicine has culture that can be a little bit problematic for coaching. Again, not to make it so that we say, well, let's throw this out and not do it, but to think about where might we need to do a little adapting. So here's one. Coaching demands direct observation. We also know that direct observation doesn't occur as frequently as we would like in clinical training. And there's all kinds of reasons for that, and the easy reasons are it's too busy, clinics are behind, there's too much work to do, there's not time. Those are legitimate, but they're not the only reason that observation doesn't occur. It also doesn't occur as often as we might like because it's actually culturally uncomfortable. Because in training in most health professions, the goal is to train people to be autonomous, not to need an observer, not to need a coach. And so people actually aspire to that independence and autonomy, and asking them to be observed can really feel like a threat to that. If you ask a senior learner if you can come and observe them, they'll wonder what's wrong, because they really aspire to graduate from the need for that. That's actually quite unlike the culture of, for example, music or sports. Try to imagine a top-level athlete that doesn't still have a coach. If you were Canada's top opera singer and you got a new role, you would probably get on the phone to a vocal coach right away and start working on it. You wouldn't just assume you could do it on your own, but health professions don't have that culture. And so, it's useful to know that direct observation is not so easy because it's a bit culturally weird for us. Coaching really works best in the context of longitudinal relationships. Not always. I've talked to sports coaches who say, well, you can go and coach an athlete for 1 hour that you don't know, and you could still do something useful, and you could. But most people's relationship with their primary coach is a long-standing. And what happens in long-standing relationships is that a lot of advantages start to accrue. The coach starts to know what works for that athlete and what doesn't work for them. They understand their trajectory really well. The learner starts to feel like the performance that the coach sees is pretty authentic because they've seen enough of it to know what's just a bad day and what's a recurring issue. Probably most important, there's a trust that develops. Personal trust, I think, that sometimes enables a shorthand for challenging conversations. Sports coaching is not always nearly as pleasant and nuanced as the coaching that we try to do in these professions. But there's also a trust in the purpose of the interaction. For athletes, for musicians, it's very clear that what their coach is doing is in their developmental interests. And that's something that I think arises out of that trust in longitudinal relationships. Now, at least in medical training, longitudinal relationships are sometimes challenging. In some disciplines, they're not so challenging. Small surgical training programs, everybody gets to know each other really well, and longitudinal relationships can really thrive. Internal medicine training programs might see a resident spend time with a different preceptor literally every week for 3 years. And so in some areas, longitudinal relationships are hard to come by. And as a result, we kind of have another reason why coaching can be a bit difficult to just slide in. In health professions, we like to match together assessment and feedback. We're often asking the same teacher to do both of these things with the same learner related to the same task at the same time. And the real challenge in that is that it can create a lack of clarity about what the conversation is really about. And then we start to get back to that issue of, do I trust that this is just developmental, or is this part of a judgment that's going to have consequences for me, and I'm interacting differently depending on what I think it is? So what my colleagues and I have called the tyranny of documentation. I cannot speak for all health professions, but I can speak for medical education, where we have a bit of an obsession with documenting everything. Part of programmatic assessment says that we're going to collect up all of those formative moments so that they can all be part of that summative judgment. And while in theory, what that's doing is giving us as much data as possible, in practice, it's actually having two kind of problematic effects. One is it's making a lot of that data of lower quality than we would hope. And number two is that if we're hoping people are going to engage with something in a formative way, when it is going to be recorded on a form that has the word assessment on the top of it and then sent to a competence committee, well, it might just be hard to get the kind of developmental impact from that we hope that we're going to get. So we're maybe over obsessed with documenting. And the last thing I'll say is that vulnerability, a freedom to fail, is actually pretty challenging in medicine, and in fact, in most of the health professions, for all kinds of reasons. The easy reason is, well, patients have to be safe, and it's not always safe to have learners fail. But the other reason is that, if you talk to residents, it sometimes feels as though residency is just one long job interview. People are very concerned about the next steps in their career, and I expect this is probably true in any health profession. People need to get employed at the end of their training. And so everything, every day, every moment can feel a bit like a performance in service of that next thing. That makes it hard to actually just fail spectacularly and enjoy the learning that can come from it. Because you're a bit worried that maybe it's not safe for that to happen. Maybe that's not safe reputation. So. Okay, so I saved one slide for some solutions. But I think that the idea of coaching and the idea of providing more tailored developmental learning conversations in clinical workplaces is really important, is really useful, and has a ton of potential. But I think we will never get there if the only way that we try to get there is by teaching people how to be coaches and teaching people how they should respond to coaching. We also have to think a little bit about what are some of the structural things and cultural things that we need to grapple with in order to make coaching a fit in our environment. The first is, I think, making space to foster longitudinal relationships. If we have the luxury of creating at least one longitudinal relationship for a learner with a person who is not directly connected with their assessment, that could be useful. That's not always possible. And so as a compromise, sometimes we have really small programs and they don't have the luxury of having coaches over here and assessors over here. At least within longitudinal relationships, it's a little easier to be clear. Today's conversation is about assessment. This is a judgment conversation. I'm going to tell you whether or not you've met the mark. And then next week, we're going to go back to some developmental feedback until the next conversation. So within longitudinal relationships, trust can develop that, I think, can make that possible. Second thing is to really think about how we meaningfully lower the stakes, keeping in mind that stakes are in the eye of the beholder. It is not about just saying, no, this is a low stakes moment. It's about really making things a low stakes moment. Or ideally, as close to a zero stakes moment as possible. I personally think that one of the ways that we do that is that we stop writing everything down. We have to collect some information. We absolutely have to document and collect information. But maybe we don't need to document every single feedback conversation, because the act of documenting changes what that thing is in ways that make it not as effective as a formative conversation as we would hope. So I think creating some space where we say, we're just going to have this conversation. We're not going to write anything down. We're not going to document it. If you want to make some notes, for you to refer back to as a learner, that's okay, but we don't need them. We're not keeping them. I think that may be helpful. We can never get these moments to be zero sold, but I think we can get them more. And then the last thing, just a little bit of a matter of terminology. One of the great advantages of the word coaching is it actually removes the word assessment. I think the problem with formative assessment is that the word assessment dominates what that is all about. So I actually would favor formative assessment being the language of curriculum developers and educationalists and education scholars, but in the front line of teaching and learning, we should talk about conversations, we should talk about development, we should talk about coaching maybe, but we should be really careful with our terminology, because when you call something formative assessment, I think it just brings as assessment. So I'm going to stop there. I thank you again for your attention, and I'm happy to take any questions.
Thanks, Chris, for an excellent presentation. We've pushed our buttons a little bit, which is always a good experience. I have long championed the idea that we should divorce the coaching and the assessment. And the answer usually is, well, I come from a small program, you can't do that. Do you really believe that argument? If you may have two faculty members, and let's call it two residents, I'm the assessor for one, the coach for the other, and vice versa. What do you feel about the logistics, or does that feel like a practical solution? Because as I've heard from the literature, that it takes a single assessment moment to contaminate that relationship of, you're not really my coach anymore, you're my coach in my name, but I'm waiting for that assessment moment to be captured there, and then hence every kind of interaction I have might be on the public record.
Yeah. I do think that divorcing those two things is probably a luxury that educational programs with a few more supervisors in fact would have, and very small programs would really struggle. They would partly struggle because I think that if you only have two faculty or three faculty, we had a residency program in Western University faculty, a couple of them. And I think it's probable that in those circumstances that if you didn't dual purpose your faculty, you might actually be losing something in terms of what they could deliver. I think this is another area where things are a little different in health professions training than they are in sports. In medicine, to some extent, all of our teachers also have a responsibility to society. They have a responsibility to help and support and coach and facilitate, but also to make sure that they hold people to certain standards. So the great advantage that small programs have, I think, is relationship. I've started to think that around feedback and coaching, no setup is perfect. Either you've got 100 faculty to draw on, but everyone's anonymous and there's no longitudinal relationships, or you've got two faculty to draw on who have to do multiple roles, but everybody knows each other real well. I think there's a lot of interacting things. If you have a little more relationship, then maybe that actually can compensate for a little less ability to neatly separate the roles. I also think that the idea that you can't be a coach and an assessor is very appealing to say, and some of this data suggests that it can be problematic to combine them. But I think it's an area that needs some research because it's a reality. And I think sometimes actually just problematizing things in ways that ask people to do things that are unrealistic doesn't get you very far. I also think that a lot of the notion that we should separate coaching and assessment is not really so much empirically based. And so we probably need a little bit of study of how effectively learners can distinguish those roles and interact comfortably with both roles when a relationship is kind of in place. And I think there's some settings to do that. Small residency programs, longitudinal integrated clerkships, places where relationship is at the center, but where it's likely, because of the low number of supervisors, that learners are having to interact around both assessment and coaching, and to really understand a little bit better how they navigate that. Because I think in some cases they do navigate it. You can see situations where learners actually, after a while, want their coaches to participate in their assessment because they would say, well, that person understands me like nobody else around here does. So I don't think I don't see quite a clean separation of those two. I think we have to figure out how to navigate their almost inevitable combination. Yeah.
Thanks so much. I enjoy that and it's really helpful to reflect. And I found myself perseverating on the word judgment a little bit. Thinking back to an editorial, remember the coaches can be judges.
Yes.
And also the challenge in the same space, Jenny Rudolph's work of debriefing with good judgments into lines. And the point that she makes that you need judgment to provide development
And it seems like that concept actually spans both worlds, the world of coaching and the world of assessment, even though it might feel uncomfortable to be judged. I'm still wrestling with the idea that you have to be judged in some way by a coach or coach. And I wonder what your comment is.
Well, when we've talked to coaches, people who primarily spend time with coaching, I think they're not so uncomfortable with that idea. The coaches that I've talked to are pretty content with the fact that they're constantly making judgments and they're constantly assessing. They feel like that's their job. I think what they're also clear on is what that is in service of. So the judgment is not an end in itself. The judgment is a means to an end, and the end is, how do I make that better? How do I help that person go faster, jump higher, to be more accurate at whatever they're trying to do? I think sometimes in medicine we have a tendency to view, when we talk about feedback, that judgment is bad. But of course, to give any kind of feedback, to give any kind of useful coaching to a learner requires that you make some kind of a judgment. Getting back to that initial idea of formative assessment, you need to sort of have a judgment for yourself of how close or far away are they from the aspirational standard that they're aiming for? And what are the things in your judgment that would be most helpful in moving them along towards that? So, I guess I think the words we use probably matter. But coaches make judgments all the time. It's just what they do with them, and I think that the beauty of sports coaching or music coaching is that there really is very little doubt most of the time that what they're doing with those judgments is trying to funnel them constantly back into how can I use that information to help that person to make that thing better, to kind of move the performance forward.
We have someone from the online audience who'd like to speak their question.
Okay.
So, Melina?
Hi, Chris. Thanks so much for that talk. Really interesting, particularly around the documentation piece influencing the feedback conversations. My question is, well, comment and question. It's interesting because you've done such a great job differentiating and elaborate on the different kinds of assessment. And so I'm just learning about the world of coaching. And it's actually also quite varied, as you may know. And I think you're really speaking to performance-based coaching, or maybe even switching into developmental coaching, which is completely different than transformational type coaching, where actually you need to separate judgment of what is happening. And so I wonder if you have thoughts on the role of the different kinds of coaching in the same way that we've sort of started to elaborate over the last couple of decades, the different kinds of assessment, because I think the performance versus developmental, which overlap, versus transformational, where you're really distancing yourself from a judgment and it's not an expert role, is interesting. And if there's a role for that as well.
Yeah, what a great question. There may be a role for that. I think I don't know that I have a particularly smart response to that. I will say that I think it points out that we sometimes make assumptions that we understand what we mean by certain terms, and that the term coaching is just as problematic in that regard as assessment and other things. Coaching is not always the same. Its goals are not always the same. And I think that, transformational coaching may well have a role, but I think that we need to be careful that we not just call everything the same thing and yet expect very different kinds of behaviors in different circumstances. I think the more we can be really clear in fairly straightforward terms about what it is that we're trying to accomplish, what do we need to happen here? And can we have, learners and teachers, coaches, and those being coached at least consistently on the same page about what the interaction is meant to be about, what is going to happen, what's not going to happen, what the consequences of it are. I think a little bit of conversation like that at the start of any kind of interaction is really helpful, because sometimes an interaction is straight up about judgment and assessment. It's just better to be clear about that and then people know what they're dealing with and they know what the conversation means. But I think too often we don't do that. So I think I kind of dodged the question a little bit, but it's a good one. I'm going to think about that.
Thank you, Tom. Yeah, I was thinking about the same thing, like, is there a time and a place for specific types of coaching and passing judgment? So I'm struck with the idea that a coach, of course, is making decisions about how well you are performing, but whether or not you're going to be first string or sitting on the bench is, you know, a judgment that they're going to make that relates to performance.
Yes.
But at the same time, performance might be winning or losing a game and the outcome of that. And those are kind of different facets of, you know, what we might expect on an athletic team and, you know, how that might parallel in a clinic or in a classroom sort of thing.
Yeah. Well, I think that for me highlights that context is hugely important. I'm not a sports coaching expert at all. We studied a particular brand of sports coaching, which has a very strong developmental intent. I was so heartened to know that varsity sports coaches want people to graduate as better human beings. And they really, across the board, did not care all that much how people performed on the field. Really lovely. But we also recognize that that's maybe distinct to that context. If you're the coach of the Raptors, that's probably not your context, right? Even if you're coaching a team sport where you have to make decisions about rostering, well, there might be something interesting to learn for health professions about that, because then that's a situation where you have a sports coach who does need to blur together the judgment role and the developmental role. Similarly, music coaches who make decisions about who gets what role based on auditions. That's sort of an interesting context to study. I think maybe that's kind of the next frontier, is to look at those messy areas where people actually do have to navigate roles that are not the same in every context, because that actually probably comes a little closer to what we're trying to look at.
Thanks so much for sharing your insights. I'm still hanging on the teaser that there might potentially be some thoughtful ways to move away from the tyranny of documentation. And I wonder if you have any further thoughts about how health professions education could move away from that tyranny and those expectations in a positive way, while being mindful of potential losses that could be mitigated in any move away from this oppressive push for documentation.
Yeah, for sure. As someone who's going to lead the Royal College in about 6 weeks, I want to be a little thoughtful about what I say. I'm not speaking for any national organization. What I would say is that I think we're actually fooling ourselves if we think that the documentation is valuable. This sort of oversupply of data, or an aim to have an oversupply of data. It is well intentioned. I think the psychometric argument is surely more data is better. You've probably all seen these sort of mosaic pictures, and the kind of smaller the pixel, the more pixels we have, that the brighter and clearer that picture becomes. I think that's actually only true if each piece of information that you have is of good quality. And there's probably a kind of a tipping point. And once we are past that, the requirement for a certain amount of documentation actually just pushes us to create low quality data, because everything can't be high quality if that's the bar that you've set in terms of the amount. And so then you have a mountain of mediocre data, and suddenly that mosaic doesn't look nearly as clear as you had hoped that it would be. And also you've wasted a lot of the potential formative or developmental potential of some of those moments. So of course we need to document. I would really favor thinking about trying to sell people on the idea of fewer instances of higher quality data and time reserved for conversations that are not documented. And just thinking about those as separate things. We don't need to know about every feedback conversation. We maybe need to know institutionally that there is an environment where feedback is widely available. You know, we do need to make sure we have learning environments that make space for those kinds of conversations. But that doesn't mean that we have to be listening in and know what the conversations consist of. So I think what I would do is I would favor higher quality, lower volume documentation and explicit attention to conversations that are informal, that are coaching oriented, that we maybe would like to know happened, but we don't need to know what happened. That's kind of where I see that going.
Okay, I think that's all the time we have. Thank you so much again, Chris, for a lovely presentation. I think we all have a lot to think about. So thank you so much again.
Thanks so much, Chris. I've heard you speak several times, and you always have this way of kind of peeling back the veneer of the colloquial and causing us to really dig through the wood that's underneath. You call it problematizing, and I'm excited to see what how the rhetoric maybe changes in 6 weeks, but the impression of documentation is an interesting phrase to come into. So my name is Rob White. I'm the Vice Dean of Education for the Faculty of Health Sciences. Thanks everyone for joining this evening online. Now I have the pleasure of introducing you to the recipient of the Dr. John C. Sibley Award for Excellence in Education for Part-Time Faculty in the Faculty of Health Sciences. One of my joys in adjudicating this award is seeing all of the great contributions that part-time faculty are making in our faculty, and I wish actually we could advertise to you the submissions of all of the nominations each year. Elif commented on the role that Jack Sibley had in overseeing residency programs. I just want to broaden the commentary about Jack Sibley. And so if you'll bear with me for a couple minutes, and if you can keep track of the professions that he was involved with in his time with the medical school, I think it's very impressive. And it speaks to the interprofessional nature of the award. John Sibley, who went by Jack, he first appeared on the McMaster scene in 1967. He was an assistant to the founding dean of the medical school, John Evans. John Evans assigned Jack Sibley the task of developing educational and clinical programs in chronic diseases and rehabilitation. Jack Sibley's first task was to work as the executive director of the rehab hospital, getting it built, recruiting the faculty, recruiting the staff, and getting the program started. Together with Alan McNaid and Adrian Jaffe, Jack had started the cardiac investigation unit at the Hamilton General Hospital in the 50s. At about the same time, he had been instrumental in founding the Hamilton Institute of Physical Medicine and Rehabilitation. When Jack Sibley was beginning to become involved with McMaster, he remained head of the Department of Medicine at Joseph Brant Hospital in Burlington. His initial responsibilities to the medical school were significant and were contributed as a part-time faculty member. Sibley was closely involved, along with some other McMaster Medical School founding fathers, such as Jim Anderson and Walsh, in developing a cooperative program with Mohawk College and McMaster University for teaching physio and occupational therapists. While he was chair of the Health Professional Education or Post-Professional Education program in Faculty of Health Sciences, he oversaw the development of the Nurse Practitioner program, the Clinical Behavioral Sciences, and several other programs. Eventually, he went on to be the Director of Residency Education and worked also to oversee continuing health sciences education. He organized the Academic Studies program. So Jack Sibley had a huge influence on the early development of the Faculty of Health Sciences, as well as interprofessionalism in our faculty, and that really became the foundation of what are one of the tenets of our faculty. So in this spirit, the John C. Sibley Award for Excellence in Education for part-time faculty recognizes part-time faculty members who have made contributions in 4 major dimensions: development and evaluation of innovative educational activities in health sciences, support of interprofessional education, sustained commitment to the academic mission, and impact on teaching and learning in faculty of health science programs and initiatives. And this year's recipient of the John C. Sibley Award has robustly demonstrated sustained commitment across all of the award dimensions. So I'm going to introduce you to this year's recipient, and then I'll invite him up to say a few words. Dr. Mohammed Al-Rakia is a family physician and is assistant clinical professor in the Department of Family Medicine in the Waterloo Regional Campus at Maastricht University. Mohammed is described by peers as a visionary, a collaborator, one who demonstrates great commitment, and a great role model for learners in the undergraduate and postgraduate medical education programs. Mohammed holds the faculty leadership role of digital health and innovation lead. He has led the development of unique educational experiences for medical students and residents, including participating in pitch competitions and hackathons where learners can trial and evolve their innovations. By way of Accelerate, Mohammed supports innovation through his work with accelerators and incubators in the Waterloo region, connecting clinicians and medical learners into the innovation ecosystem. Mohammed has redefined health interprofessionalism, connecting medical students, residents, and physician faculty with engineering students in the University of Waterloo's engineering capstone projects, as well as bringing together medical students from Waterloo, Hamilton, and Niagara with business students and engineers through his support of a student and resident-run interest group called KWSIM. Mohammed has also brought his digital expertise into our traditional learning spaces. He produced a curriculum guide to facilitate the inclusion of digital health in tutorial materials for undergraduate medical education. For clinical clerkship, he developed curriculum around the guidelines for professionalism in virtual encounters and technology in intensive care. And for postgraduate learners, he created curriculum for family medicine residents on understanding how to leverage information systems. Mohammed has published academic papers on digital health and acts as an expert at the provincial and national levels with government and leadership committees in this space. In the words of one of his colleagues, Mohammed is a respected and valued contributor representing Maastricht University with pride. I agree wholeheartedly and take great pleasure in introducing him to you today as the 2024 John C. Sibley Award recipient.
Like a long list of winners. It's really an honor to be here. But I will say that this is not just for me. It really is about the colleagues at the Waterloo Regional Campus. It's about the colleagues in Hamilton. The Department of Medicine has been really instrumental in looking at a vision where we do something different with learners. So if you know a little bit about the Watling region, it has the highest concentration of startups, actually more than Silicon Valley now with health tech workers. And so it really is a different culture, a different environment where when we started a medical school there, we thought there's something unique here that we can take advantage of. And so we really haven't had a chance to do that until now, where we've really established the satellite campus there and we've said, you know, we need to leverage this ecosystem around us, this culture of innovation, entrepreneurship around us, which, you know, as a clinician who actually did my residency in the area, we're just trying to be a doctor. You don't have time to think about changing the system, but we should be thinking about changing the system. And so that's what we really wanted to instill in our learners in that area. And so, you know, before I go on, I would like to thank my nominators, that includes Dr. Crowther and Dr. Sawyer, Dr. Margot Montjoy, who is the Regional Assistant Dean, as well as all the faculty at the Waterloo Regional Campus. You know, we talk about healthcare, and we talk about, you know, we produce leaders and students in healthcare that we want to be great at delivering patient care to the patient. But we also want them to be system leaders. You know, when I did my master's after my residency in health information science, and I looked at referral processes and wait times, looked at the 2004 health report, which said, you know, we want to solve these wait time problems. And they had a 10-year plan.
We're 20 years now from that health report, and we look around us, and while we have made some progress in wait times, we really haven't done enough. And so how do we train clinicians that can participate in that? We call them wicked problems in healthcare, and then we sort of give up. They're wicked, we can't solve them, but we can solve them. So how do we produce the people that can actually solve them? And so for wait times, there's a physician and an engineer who developed a solution that's reduced wait times of 59 days for orthopedic surgery, 53 days for cataracts, by 32 days for MRIs. This technology started in our region and now is expanded to over 11,000 physicians using technology and in 3 provinces. So we can solve these problems. We just need to create an environment where we can do that. And two, as well as mentioned before, so now we're partnering medical students, yes, with occupational therapists and nurses and optometrists, but also with engineers and entrepreneurs who think a little bit differently. And they go through the school of hard knocks, where they really are there and they need to produce and they need to deliver things. And so we pair our medical students with them so they actually see that and they understand that, and they understand that they can take their thinking and their in-depth experience of the clinical environment and actually make a difference. Because they're there. The reason we burn out and we suffer from all this documentation burden is because as clinicians, we don't really control a lot of it. There's other factors that are in place. So can we put the clinicians more to control? And if we do that, then can we help with the health system writ large in terms of empowering them? So I'm really honored to get this award. Again, it really is about the entire campus and all the supporters. And I think as we think about interdisciplinary work, perhaps we can broaden the definition a little bit and include some of our engineering and entrepreneurship colleagues into the fold. So I really appreciate it. Thank you very much.
For those that I don't know, I'm Jonathan Sherman, Sibley in Paris. Thank you for joining us. There's a group at the back talking to me. There's an opportunity to ask a question you didn't have an opportunity to ask before. Chris, the opportunity to congratulate you on it. If you don't know about Merit, you can find more about us at merit.master.ca. If you do know about us, I hope we'll see you on May 7th. Cheryl Hawk is returning from the University of Alberta to talk more about how they think about mixed methods, and how they numbers and words and start to answer some of the big problems that we're experiencing in professional education. Then June 5th, Dave Braley is our nerd day. But it's our Norman Education Research Day. It's an opportunity to see what's the scholarship that's happening within the faculty of sciences. What are the projects that are in development and what are ones that can come to completion? And where will be the next motivation or incentive? Start with it. I think that's a great opportunity to interact. So thank you for being here.